Well, first of all, I'd like to thank the organizer for inviting me to this very interesting symposium. When I entered this room and I saw Julian and I saw Marcus, I was a bit worried because I don't wear a tie. Not until Dean Yap-Sing comes in, he hasn't got even his bow tie. Then I feel I'm safe. I would like to spend the next couple of minutes to discuss with you some of the discussion that we had about 6 months ago among a group of engineers and ethicists as well as clinicians. After a meeting conducted in the Academy of Medicine Singapore, we have been asked to draw up some sort of framework guidelines for the countries to consider in future development. You see, technology has moved so fast that my colleagues in engineering tell me actually a long time ago, even before GDP4 is available, that there are lots of things that they can do, just that they don't know when not to cross the line. So they urge us to please draw the line and tell us where we should not cross, and before technology has overtaken us. So here is some background, and I feel that it is rightly so that despite the advancement in technology, AI implementation in medicine is relatively slow because we know very well that we're dealing with life and death, and our decision has much more impact than consumers, market, or even fintechs and so on. So we need to discuss a lot of ethical, legal, and social issues before we can safely and we can trust the machine in making life and death decision. And therefore, building trust and engaging healthcare workers, engaging patients, and also people from different kinds of stakeholders, including the government's agency and the regulators, is very, very important. In fact, Singapore has been doing extremely well and in this aspect, and many of you will know that in this country there is an AI ethics and governance body of language. This is initiated a couple of years ago by the Computer Science Society and the government, that they want to have a group of people constantly reviving and discussing about this issue. So it is not a fixed document, it's a live document called body of knowledge, so that when time changes, when the technology evolves, there may be modifications and changes of their guidelines. And because of that, Singapore actually win an international award for AI governance and ethic initiatives. So something that we should all be very proud of. I'm not sure whether you are aware of it, but you should be proud of it. And when I look into the website of this book of knowledge, and I actually find that they have many different sectors, from fintech to consumers to a lot of different fields, domains. But healthcare is only one of them, and it is relatively brief. And I think that we should really spend more time to discuss among ourselves, because AI has already penetrated into many different aspects. I mean, the ChatGPT-4, which comes out in the last few months, has suddenly opened up a lot of interest, but I think it is also causing a lot of anxieties among healthcare workers. So where should we go to? Now, I'm trained as a gastroenterologist, so I do not decide whether or not to resuscitate people in the ambulance. That is a very heavy decision. What I need to decide is, when I see a polyp in the colon, whether or not I should remove it, and whether or not removing it, and I should send it to a pathologist or just discard it. Now, that is still a very important decision, because if I missed a polyp, which turned out to become a cancer, or if I remove that polyp and I forgot or don't want to send to the pathologist because it is so costly and take time, then I might actually lead to a misdiagnosis with lethal consequence. So AI usage has actually allow us to make diagnosis, but also to make prediction based off the characterization of the lesions that we find. The ethical issues that we always need to base on is, we always should have the patient's best interest as our core. Somebody mentioned that. Autonomy and values of the patient should always be upheld, and justice should prevail. Now, this actually comes from Julian as an expert in this area and with the legal training. And because of that, about 6 months ago, I think it's about 6 months ago, a group of us have discussed for the whole day and tried to draft a number of statements. Now, these are not meant to be definitive, and the purpose of drafting this statement is really to arouse public's interest and discussion. And this statement, after circulated among us, has been endorsed by the Academy of Medicine Singapore as well as the College of Physicians and the GI chapters. So I'll go through this statement with you. As I said, the purpose of doing this is a group of professionals and academic people come together and try to promote the best interests of patients in the development of AI and arouse public interest to discuss this so that ethical and social aspects of AI would not be ignored. So the first statement that we've drawn, I don't know where you can see that, it's deploy AI tools should have maximum efforts of explainability and interpretability. Now I understand what's the difference between them, unless there are clear benefits of patients of the black box model. Now here, the statement is try not to exclude black box. All right, because there are actually a lot of things that we still don't understand. Even if we are practicing every day, I don't understand why aspirin actually helps to prevent cancer at the same time prevent coronary heart disease and also heal my headache. But we have been using it for 100 years already. So not everything that we are using can be explained by our present day knowledge. However, we know that it works and then we are using it. But so we are not trying to exclude it. Having said that, we should still put our maximum efforts to enhance explainability and interpretability. You can just imagine if I use an AI tool and it comes up with a certain recommendation, which I would use, but I tell my patient, I actually don't understand why is that recommendation come about? And I don't understand what would be the consequence of it. Only 1 minute left. Okay, so I don't want to explain to you anymore. Second statement is that AI tools should be deployed continuously for improvement with feedback and transparency. So this is the unique thing about AI, and that is it is not a tool which is static. It continues to evolve, and we should allow it to continue to evolve and improve by feedbacks, by understanding why the mechanisms behind and then the algorithm. Number three, the AI tools should assist but not to determine decision-making of the doctors and patients in clinical medicine. And that is pretty much just covered in our panel discussion. I think the tools should only be used as a reference for doctors, human doctors, to make a decision together with the patient. It should not take away the autonomy of our patients as well as the healthcare providers. I think that is important. And also AI should be used only when users know when it is being used. So somebody say, well, sometimes we are using a tool, we don't even know whether it's AI or human decision. Now that probably should be avoided as much as possible. If you are using a tool and there is an element of AI, you should know about it and you should let your patient knows about it. Otherwise, there will be no consent. There will be no way that they decide whether to use it or not. So as much as possible, we should be very, very transparent. AI should be developed and used in such a way that it respect and promote patients' value. So it's not all the time right or wrong decision. It's not all the time how many % of survival probability or death. But sometimes you have to respect people's choice. You have to respect. I always tell my medical students that when you see patients, when you make decisions, patients' dignity should not be forgotten, particularly in geriatric patients. You think putting all the tubes and giving all kinds of funny drugs, keeping the patient's heart pumping and the lung breathing is the best thing that you can provide for them. But no, they may not be. The patients who are receiving all this, they should be asked whether or not they want to receive this treatment. Patients' data used by AI should be private and confidential. I don't think we need to explain this. Equity has been discussed earlier on, all right, because tools like this should actually be used to provide equity of healthcare and not to increase the disparity of healthcare. So equity, I think this cartoon drawn very well to differentiate between equality and equity. So you are not giving everybody the same stool so that they got lifted to a certain height, but you want to have everybody benefit equally from the treatment that you give. So AI too should be developed, used in consideration of all ethnic, age, gender groups, and all social class, and it should not reinforce or exacerbate existing injustice and discrimination. And this is not just about money. Okay, when I come to Singapore, I find that if my IT technology is a little bit less than what I should have, I would not be able to survive in this country because everything I buy, I cannot use my cash. You have to use the pay now and pay later and pay whatever. And so if AI is to be used for healthcare, we should try not to exclude the elderly people who are not technology savvy, but to include them. So we have to consider this aspect and also to make it affordable and accessible. I probably passed my time now. AI should be validated with solid and robust clinical evidence. So just now there was a question whether RCT is required. My answer to that is, well, we may not need RCT in each and every case, but we still need robust data. A lot of existing data about AI tools is measuring something which is experimental, is imaginary, all right? I've seen a lot of studies comparing AI tool for stroke rehabilitation. They are measuring this score and that score, but what does that mean to the patient? What I want to see is that you have some tests to show me that this AI tool help the patient to walk faster, help the patient to be discharged from hospital earlier, help him or her to be able to swallow the meal without choking into the lung. I mean, those are the clinically relevant outcome that I need to see. It could be ideally an RCT, but it may not be an RCT in all the situation. And finally, we should have implementation governed by a regulatory authority, which should seek input from stakeholders. So it's not just a group of politicians or policymakers sitting in the office, but we should listen to the patient. We should listen to the frontline doctors and allied health workers to feedback on what AI tool should be used. So the WHO guidance, which was published 2 years ago, says very well, if employed wisely, AI has the potential to empower patients and communities to assume control of their own healthcare, better understanding their evolving needs. But if we don't take appropriate steps, if you use it inappropriately, it can cause disaster. So, and Anthony Hopkins has also said our future is a race between the growing power of technology and the wisdom with which we use it. I'll stop here. Thank you very much.
Thank you, Prof. Tsang, for your sharing. Next, I'd like to invite Associate Professor Ben Goldstein, Biostatics and Bioinformatics in Duke University, to share with us about the Algorithm-Based Clinical Decision Support, or ABCDS, Oversight Framework. Professor Goldstein, please.
And as others have said, I really appreciate being here. This has been a great afternoon so far. So I am a health data scientist academic by training, but I also serve as our chief health data scientist for quality within the Duke University Health System, and have been part of our regulatory process for how we govern AI tools within our health system. So I'm going to talk very briefly about that today. So a lot of this was motivated by the risk that we saw at Duke around CDS tools that were being implemented, things that we saw within the media, about challenges that were happening, failures of those models. And this was really viewed as a potential liability for us of how do we actually create a process around this. In particular, within the US or around the world, is really thinking about these tools within the health equity, health disparities framework, and what are challenges that how this can actually exacerbate health inequities. And in many ways, we'd been implementing tools that really had no structure around how that was being done. And then around the same time, the US FDA was starting to put into guidances that are continually evolving around how we should be thinking about this. And we realized we needed internally some kind of process to really think about how we work with these tools. So around 2018, we had about 16 models that were in production that were being used to help guide decision making. We had a committee of myself and a few other people who were there to recommend best practices, but really had no teeth behind anything that we did. We were really just there to be recommenders. Today, we have over 40 registered tools. We have a bunch more in production. So we have a much bigger environment that we really need to be thinking about. And around all this, there's a very complex environment. We have users that are coming at this with different skill sets, different knowledge bases. They're using different types of resources. The project teams are quite different, and the way the models are coming at them are quite different too. We have models that are coming from our EHR system, models that are coming from external vendors, models that are coming from internally developed tools, and models that folks are saying these are best practices for our society. We need to be using them because this is what our society says to use. So this led to the creation of our ABCDS Oversight Committee. And what to me is really quite unique about this, and the real success behind this, is that it's a partnership between the health system and the School of Medicine. And we actually have individuals from both sides of those fields working on this committee. And that, I think, has really been a key component of that structure, and I'll allude to that a little bit. So the overall mission statement is that the primary focus is on patient safety and higher quality of care. Our mission is to guide algorithm-based clinical decision support tools through their life cycle by providing governance, evaluation, and monitoring. And there's a really key point here, is that not in our mission statement, so it's not part of our jurisdiction. We are not making any statement about the importance of the tool. That is for other people to decide. We are just simply governing through the tool's process. Should the tool be used? Is the tool important? Is the tool necessary? That is for other people to decide. We are here just to simply say, let's evaluate the tool itself and understand how that tool works, so that decision makers that are making that final decision of a go or no go about the tool can make that appropriate decision. So the overall structure behind this, I want to highlight a few people. So as the co-chairs is Michael Pensino, who is the Vice Dean for Data Science on the School of Medicine side, and Eric Poon, who is the CMIO on the health system side. And that is the basis for the health system School of Medicine structure. And then we have our three main subcommittees. Probably the most important subcommittee, they're all important, is the regulatory subcommittee, and that is housed by actually lawyers. And they're the ones who are really understanding the FDA guidances and are interfacing with the FDA to understand what is the regulatory framework. There's myself and Eric Jalosvik, who is a clinical data science clinician. We lead the evaluation subcommittee, and then we have two clinicians who lead the implementation and monitoring committee. And then we have other committee members to highlight, for example, Michael Carey. He is our health equity scholar, and he's really looking at our processes from a step back health equity lens. So I'm going to talk very briefly about the process that we go through. And we've tried to model this so in the FDA, they talk about software as a medical device, SAMD, and we've tried to model this process for what a medical device would be, how it would be regulated and approved within the current FDA guidances. So you have, for a medical device, you have your preclinical, pilot, pivotal, post-marketing strategy. We've taken that. You may also have, if you don't have to do a trial, you may be using retrospective data. And we've taken that and turned this into our process, where we have our model development period, we have a silent evaluation, an effectiveness evaluation, and a general deployment. Between each one of these processes, we have these series of gates recognized by G, where evaluations and assessments are made to determine, can you move on to the next stage? So we have these four main periods, and we're making evaluations at each one of these points. So what are these stages all about? So in the retrospective evaluation, we're really trying to understand model performances. We're getting all that historic retrospective data. We're making assessments about health equity. This is where we're getting really important and vital information about what is the underlying error rate of the tools. As the evaluator as one leading the evaluation of these tools, what I'm really looking for is give me the metrics that you care about. Is it positive predictive values, sensitivity? How does your decision rule work? What is the error rate around that decision rule? Again, I'm not making an assessment about whether that is an acceptable error rate, but do you actually meet the spec that you've set for yourself, and then others can make the decision that a 25% positive predictive value or 90% sensitivity is good enough. After that next step, we move into a silent period workflow assessment. This is really to make sure that that translation from retrospective data into prospective usage works. And not to go into too much detail, but that process of implementing a tool inherently changes the tool. The way the data flows through an EHR system is not always reflective of how the data is captured in a retrospective context. So it's essential to have that workflow assessment to understand how that tool, how the data is going to flow through, and do you get the information you expected to get from the retrospective context. Then we move into a prospective evaluation. We've done both randomized and non-randomized evaluations. As an academic data scientist, I love it when we can do a randomized evaluation, though I'm very pragmatic and recognize that randomized evaluations are not always feasible. And so we try to work with what's pragmatic in the context, but in particular, we're looking at in that evaluation stage is not the performance of the tool, but actually the impact on clinical outcomes. Because at the end of the day, the tool is a means to an end, and the end is the clinical outcome, and we're trying to see, does it actually improve clinical outcomes? Then finally, we have the ongoing and monitoring assessment, and this is where we have the opportunity to see how does it, once the tool is deployed, we want to avoid what we term zombie models, where you have tools that are just being used, no one's looking at them, no one's monitoring them, the person who advocated for them has left and moved to another institution, no one knows who the clinical owner is. So every tool that's deployed has to have a monitoring plan in place where there's some regular assessment of that, and we can understand, does it need to be changed, recalibrated, or in some cases, de-implemented. I'm going to talk very briefly about model equity because this is a very important concern for us. Our guiding principles for model equity is that the CDS should perform as equally well as possible across different patient populations. We refer to this as no algorithmic bias, but also that interventions resulting from the tools should be equally allocated to patients of greatest need, independent of patient demographic, which can be thought of as algorithmic fairness. And then a couple of guiding principles for assessing model equity is really what I like to say is that this is an open area of work. There is no best practices here. And that in many ways, how we assess model equity may not always be possible based on actual clinical data, and that there's often going to be a need for qualitative assessment to understand how a tool is performing. We can't always rely on the observed data to assess model inequity. I'm not going to go too much into here because I'm being pressed for time, but there are different mechanisms in which we think about how model inequity may arise. For example, this notion of differential observability is really something that you just don't have the data behind it, and you can't actually truly assess it. We have thought about a couple of different strategies for model equity. But I do want to highlight this last point here, which is the role of the academic in the process, because I think this is actually really important, because again, the success of this process, I think, has been this joint partnership between the school and the health system. And I think there's a lot of value to be gained from creating this partnership. For the benefits for the health system, you're able to integrate best practices for design, analytics, reproducibility that's fit for purpose, and you're able to develop an understanding of how the ML actually work. Try to break down that black box, and you can get objective evaluators of the process. I'm one who really doesn't have a lot of stake in the game. I don't really care, is it this tool or that tool? I'm really trying to focus on these evaluations from an academic lens. And in many ways, just to, that the publications really do further the brand of the health system to show that you're at the cutting edge of doing your work. On the other side, there is benefit to the academic to being involved in these processes. You're able to publish best practices for model development and evaluation, identify open questions in need of further exploration, and engage in questions of impact. And I think it's something that's important to point out, though, because there does need to be a bit of a culture shift to get these two groups to work together. There tend to be, at least at our institution, but other institutions with which I've spoken, a degree of distrust between each of these sides. The academic not feeling the health system is really going to value their contribution, and the health system not feeling appropriately so often that the academic is going to hear the questions that they care about. I think if these two groups can talk well to each other, there's a lot of really exciting opportunity for synergy. Really briefly, some lessons learned that we've come through here. This process can really be thought as a team sport. You need a lot of different stakeholders engaged. Culture shift is a challenge and something that we're constantly dealing with. We've been in business, so to speak, for 3 years, and it's still a challenge. That being said, there's a huge benefit to a centralized governance system, particularly one that has the backing of leadership, that we can go back at the end of the day and say, look, the other people who may fight back towards us, they know that the leadership cares about this, and that they ultimately and the leadership trusts our judgment as a committee. But ultimately, still, there's not a lot of there needs to be a lot more conscious decision making, and the need to really regulate who gets to build these models. Just to kind of throw out, there's a lot of information about our process. We've published this as well, and I thank you.
Thank you, Professor Goldstein, for the presentation on ABCDS. Moving on, we'd like to invite Associate Professor Yeo Keng Keong, Deputy Group Chief Medical Informatics Officer of Research in SingHealth, to share his experience with AI governance in SingHealth. Professor Yeo, please.
Thanks very much. Good evening, everyone. I think I don't have much time, so I'm going to cut to the chase. So you have heard much earlier on, and I think maybe we don't have to answer some of these questions. Just let me jump to what we have. So we are here on the Outram campus, and I think we're asked to illustrate what we have at the cluster level. So these policies arise from different groups within SingHealth, just to highlight some of the policy that govern data use, as well as the use for data beyond research, as well as on the role of governance in AI within the SingHealth AMC. So I think for data governance, we have different groups first that look at the use of data. You have the Office of Data and Digital Governance. Chok Ming is here, who leads that department. We have the SingHealth AI Office. There's the Office of Insights and Analytics, the SingHealth Medical Board and its institutional boards, and the Office of the Deputy GCMIO for Research, which look at data and its use in the context of research. So with that background, I think we look about classifying risk levels of AI products, and we have already seen a little bit of this in terms of the earlier discussions on human in the loop, human over the loop, and human out of the loop processes. I think these terms are self-explanatory. And in that context, we have how SingHealth has classified the risk levels of AI products is relevant in terms of this in the loop, over the loop, and out of the loop definition. So in terms of healthcare administration wellness, the risk is felt to be low, and therefore you can have, if you have human in the loop, the risk is felt to be medium for such areas if it's human over the loop or human out of the loop. And for treatment, patient monitoring, diagnosis, and screening, you can see the different risk classification. And I see Ben frowning and trying to figure out what we are saying here, but maybe I'll take it through then. So if it is human out of the loop, then the risk is felt to be high. I think that makes sense, right? I mean, if you have done, and I think Prof. Song has alluded to earlier on that if humans are not involved, then this is considered high risk and probably would not be kosher in most jurisdictions. On the other hand, if a human over the loop or human in the loop, then the risk is felt to medium. This is what the cluster has felt to be relevant risk levels. So with that risk level in mind, what is the approval process for AI products? The product owner submits approval form to the AI Evaluation Committee. The AI Evaluation Committee reviews, endorses, and the product owner then seeks approval from the approving authority, and the oversight committee then updates this in the master AI inventory list. So this is a way of the healthcare system trying to operationalize some of the concerns raised earlier on. I just want to highlight a few key points here in this slide. One is there is a product owner. Somebody has to own this, whether it's updating the product, applying for regulatory approval, etc., etc. So this is really important. It cannot be left alone. And there are various committees that reviews, endorse, but there is a approving authority. And what is this approving authority? And here we go back to a template that was created. So again, for healthcare administration wellness, that approving authority is the GCDSO, titles and acronyms kill us all, but here they are as a Group Chief Digital Strategy Officer. Sorry, I get it wrong too. The D can stand for many things in life. And then for the treatment, patient monitoring, diagnosis, and screening, it is the Group Chief Medical, the CMB, Chairman Medical Board. Or if it is just institutional, then the CMB for that institution. So I think that this illustrates the context upon which these tools are approved. So at the bottom right, where you have human out of the loop, and in treatment, patient monitoring, diagnosis, and screening, requires the Health Services Authority to approve it, which is a national body, of course. There are various governance committees, as I mentioned earlier on. The Governance Oversight Committee provides oversight of governance matters on AI products and maintains the inventory list of the AI products within the cluster. And for the Evaluation Committee, it reviews and endorses the AI product approval form, and also provides an objective assessment to the approving authority. So obviously, if this evaluation committee doesn't think that this product should be used, then it is very unlikely that the medical board will approve it. There also in this particular policy a statement that we should continuously review and monitor all AI products, I think along the lines of what Ben described in Duke as well. And I think the reasons are clear why this is important. The frequency of review is as stated here. I think this is just to give a sense that of what is important. For example, for the out of the loop, there's at least half yearly. I'd like to add that the nation has published guidelines on the use of AI in healthcare. And again, some of the key recommendations are already alluded to by the previous speakers. I know I'm ahead of time, which is good because we would have a bit of time to talk about repairing innovation, and this looks at how people can deploy AI in society. And this is a very old paper from 2020. I'm not going to talk too much about it, just to say that even as we deploy AI, a lot of it is about how AI is a social technological innovation. It is not quite enough to have a product that works. How you then deploy it in real life is important. I'm going to stop here because I think the meat of the session is actually in the discussion. This segment here is just to say that the healthcare cluster is also grappling and trying to learn how to deploy AI in clinical practice. And these guidelines, which I just shared, this policy paper, the author whom sitting in the audience has just been approved only this year in 2023, showing how much this is an evolving field, and we will hope to have a robust discussion with everyone on it. So with that, thank you very much.